Good afternoon to everybody. My task today within the webinars of a GoU course is to tell you what surgeons must know about rare tumors. That is quite a niche argument, but quite important. So we have to define first what rare tumors are. We define rare tumors as tumors with an incidence less or equal than 5 cases per 100,000 people per year. Rare cancer are divided in 12 families, and they are composed by 198 histotypes. As you see here, rare cancer, the families are in the majority solid cancer, adult solid cancer families, so female genital, male genital, skin, thoracic, urogenital, sarcomas, digestive, head and neck. We have two niche arguments that are rare hematologic cancers and the pediatric solid cancers. This is the distribution of the 12 families, as I told before. As you see, the most represented are hematological malignancies, followed by digestive tract and head and neck, and female genital tract. The other arguments, the other cancers are more rare within the rare group. But why do we have to matter so much about rare cancers? Because rare cancers are not that rare. Every year, more than 500,000 people in the European Union are diagnosed with a rare cancer. And if you look at the figures here, you can see that the 22% of solid adult cancer or solid cancers are rare cancers in our country. So they are 1/5 of the entire incidence of new cancers per year in Europe. So is an issue, this kind of problem. But the real issue is not the incidence. The real issue, as you see here, is the bad quality of the outcomes. I mean, evidence suggests that survival rates for rare cancers are lower for common cancer than for common cancers for any age group, and that cancer patients in the different regions of Europe do not have equal access to proper treatment. You can see here, these are the figures that you can withdraw from the Rare Care Cancer Project, that is a European project. But as you see here, also in the United States, you see more or less the same trend. Rare cancer have a poorer prognosis in terms of relative survival compared to common cancer. You may think that this is an issue linked to the complexity of caring rare cancer, but the problem is another. As you see here, these are the survival, the oncology outcomes throughout Europe according to the Rare Cancer Care Project, and you see that it is the mean values of survival, 5-year survival in Europe. But as you see, there are huge inequalities throughout the countries. So the inequalities, you can explain inequalities by the complexity of treatment, but you can think that the problem is the different availability of proper treatments, of proper management of these cancers. As a matter of fact, the relationship between outcome and management is very tight in rare cancers. Rare cancer have a long-winded way in terms of management compared to common cancer, who have a straight line for their management. So, what is the real challenge in rare cancers? The real challenge is the ability to recognize the correct tumor type and to establish the right relationship between tumor type and proper treatment. And you can achieve this kind of result only by building centers of experience. That is, referral centers with experienced pathologists for diagnosis and multidisciplinary teams for the proper treatment. So these are the rare cancers challenges, and I can tell you that surgeons are involved in all these issues, even if you can think that they are not that inherent the surgeon's work. Why I am assuming this thing? Because surgery is the mainstay of treatment of solid rare tumors. We have to keep in mind that surgery still is the main treatment for solid rare tumor, as 2 patients out of 3 can be treated by surgery alone, and a further 30% of patients can receive a combined treatment of radiochemotherapy and surgery. If you look at the different kind of treatment we have to face according to the different rare cancer groups, we can see that every decision of the surgical oncologist has to be integrated in a multidisciplinary setting, as in fact each family of tumors require tailored decision. As an example, for retroperitoneal sarcomas, we have to plan multi-organ dissections or neoadjuvant therapies followed by a tailored multi-organ dissection. For extremity sarcomas, we have to plan function-sparing surgery. For testicular cancers, we have to perform nerve-sparing lymphadenectomy, and so on. And this is the results of the interaction of different specialists to achieve the best result, the best possible result. The main issue concerning surgery of rare cancers is that the rare cancer surgeon cannot exist. Why? Because as you see here, the burden of rare cancer in the United States, you see that according to the different districts, there is a mixture between common and rare cancers. And you see that rare cancers, you can find rare cancer in every surgical specialties. Rare cancers are almost ubiquitous and can involve every district of the human body. So it's possible to deal with rare cancers of frequent sites or rare cancers in the unusual sites of districts, which a specific expertise is required for a proper treatment. Rare cancer patients have to cope with unique problems, which are the delay or difficulty in establishing a correct diagnosis. Sometimes we can observe a huge delay in diagnosis since the appearance of symptoms. We have to review the possibility of previous errors in diagnosis. We have to expect that the patient with a rare cancer will encounter physicians who are unfamiliar with their cancer or offer conflicting treatment recommendations. And last but not least, the patient often needs to research, find experts and travel to seek care from providers. So the surgeon challenges. The surgeon has to mandatory know or better be familiar with the biology of the disease that is treating, and has to be equally expert in the district organ surgery. And so knowledge, you can reach knowledge of the biology by multidisciplinarity, but you can reach expertise in organ surgery only if you deal with certain districts with a high volume activity. So the answer to this question comes again to the concentration of rare cancer in referral or dedicated centers. I make this statement because there are several evidences about this. There is a good evidence about the role of specialization and multidisciplinarity in determining outcomes in rare cancers. For sarcomas, for example, so as you see here, this French sarcoma group has made a good number of good papers about this. And this paper is quite interesting. It deals with 12,000 patients. In this paper, they state that if you treat your patient within a multidisciplinary board, you can achieve a better compliance to clinical practice guidelines, and you have a slight improvement of quality of initial surgery, less reoperations, and better local relapse-free survival and relapse-free. As you see here, talking about the quality of surgery, you see that the amount of patients with R0 surgery, that means a radical surgery, is slightly higher in patients who were discussed in a multidisciplinary setting compared to patients who are not. You can see also the percentage of patients with macroscopic residuals of tumor are in a larger amount in the group in which patients the case were not discussed in a multidisciplinary setting. Also, re-excisions are lower in the group in which the case was discussed, and the quality of final surgery is always better. Also, survival, here data are less striking, but they are significant, as you see here. We have local relapse-free survival, local relapse, I mean, or relapse-free in terms also of metastasis. As you see, the local relapse-free survival is quite better if the patient was evaluated by a multidisciplinary team before surgery. So this is quite an important issue coming from this French group. Again, from the French group, they demonstrated that the local regional relapse-free survival curves are slightly better if the patient was managed by a specialized surgeon. Even the better surgeon who is not specialized cannot achieve the same results as the results you can achieve with a good experience relating this kind of disease. And the same thing we can observe, the same thing in other cancers like GIST. There is a paper that came from the European Cancer Organization, who is dealing with the minimal requirement, the essential requirements for quality cancer care. So in this paper, that is a position paper, you can see that it is stated that the experience of surgery is a prognostic factor of overall survival in soft tissue sarcomas. We have a lot of data about sarcomas. And how can we recognize that an experienced sarcoma surgeon? In this paper, they point out some characteristics, which are almost 50 sarcoma surgeries per year. We have to keep in mind that it's a rare cancer, so numbers are not that high in terms of incidence. This surgeon must act within a multidisciplinary environment and must be able to coordinate collaboration when necessary. Sometimes the sarcomas involve the vascular district or bones or the urological district, so you have to coordinate different specialties to obtain a real multidisciplinary team also in the operating room, in the aim for with the purpose to obtain a good radicality and also to spare the patients the most in the most efficacious way to avoid long-term dysfunctions. And the same issue concerning volume and expertise comes from some papers dealing with another family of rare cancer, which are testicular cancers. Here you see another paper who considers a huge number of patients, treated patients, 33,000, as you can see here, from the analysis of nationwide cancer registry, demonstrated that increased hospital case volume was associated with difference in management strategies and improved survival. So volume matters. As you can see here in these curves, as you see, survival in seminoma, non-seminoma are higher in high volume centers compared to low volume centers, the red line, as you see here, and as you see here. And if we want to look at another cancer, neuroendocrine tumors is more or less the same issue, or head and neck. For head and neck, the issue of radicality and function sparing is crucial. One of the things that needs some more work is defining the minimum number of surgical operations to be considered to be credentialed for this disease. We have this data for sarcomas, it's not that clear for other rare cancers. So we can state that the skillful and appropriate integration of cancer surgery and other treatments is best carried out in centers in which an experienced and coordinated multidisciplinary team is available. If you want to say a definitive phrase, I can say that competence is a broader field than performance. We surgeons are accustomed to talk about our performances, but it's very important to talk about our competences. Competence can encompass technical expertise, medical knowledge, and ability to judge and to make decisions. So we are talking about centers of experience. So how can we recognize a center of expertise? Who certifies who gives the accreditation of a center? Who says that that center is a referral one? We have two ways. One way is the use of an institutional accreditation process, and the other is a matter of oncopolicy. Our rulers, our politicians who care about our health have to take care about the importance of assessing the quality of treatment via shared principles and shared criteria. What are we doing in Europe for that? In Europe, we are working in different ways. There is a multi-stakeholder partnership initiative that's called Rare Cancer Europe. Rare Cancer Europe is a partnership of cooperating organizations that work together to place the issue of rare cancers in the European policy agenda, to identify and promote appropriate solutions, and to exchange best practice. Within this organization, this effort, there were written down some ideal characteristics of the centers of expertise. So we come again through the number, the volume of cases, the capacity to produce and adhere to clinical guidelines, to measure the outcomes thanks to institutional databases. This is very important that a multidisciplinary team is always available. It's important networking. Networking is fundamental, is crucial for the success of the treatment of such kind of diseases, because knowledge has to travel, knowledge has to be shared between experts and centers. Any new discover and a new experience is of great value to increase our results. And the importance is, as I told you, to have institutional databases, because data collection is equally important to revise our results and to obtain, to improve our practice. Another initiative, good initiative that is ongoing is the this portal, the Rare Cancer Treatment Portal, because as far as expertise has to travel rather than patients, Rare Cancer has developed this portal, is developing this portal, which will enable patients to find out information about the treatment options in their own country. As you see here, nowadays it's work in progress, but you can find for each kind of cancer what are the referral centers, how to contact them, or even ask for advices, that is for patients, but for doctors too. In this time is only an experimental starting, but we think that at the end of the year that it will be in some way working. I'm always talking about centralization, but centralization can improve outcomes in terms of quality of life, in terms of not only of cancer, of survival, but because the outcomes are not only survival. The main problem with centralization is linked to the necessity of traveling, of searching for centers. And the other issue is the logistic troubles, because you have to move, you have to plan for long staying in foreign countries, and there's a matter of expenses, a matter of, even if you have the possibility to travel thanks to the border, to the cross-border statement of the European Parliament, who allows people to search for better care abroad. But that this do not resolve all the logistic problems that this directive can create. Another issue, another criticism to the centralization, to a pure centralization, is the delay induced by centralization and time to refer the patient to the overcrowding. And for the same reason, the decision maker can lower its quality in multidisciplinary meetings due to the vastly increased numbers of cases needing review. So, is there a solution for that? In editorial that was written by members of ESO, we stated that the networking rather than reference centers per se is the key element to ensure that expertise travels, as I told before, rather than patients. The good schema, the main frame of this kind of network is the hub-spoke model, in which spokes are organized in sub-networks according to the increasing complexity of the diagnostic and therapeutic path. As you see here, the task of a reference center should be dealing with treatment planning, complex diagnosis, complex physical treatments, or complex surgery, while peripheral centers with a network and functional relationship have to deal with follow-up and can deal with less complex treatments, limiting the need to travel and to seek for treatment and help. Another crucial instrument to improve quality of surgical care for patients with rare cancers is research. Research is hardly needed, and what is hardly needed is the accrual in multi-center clinical trials because of the paucity of single series. We can produce significant results if you deal with low number series. As you see here, one good example comes from, again, from the sarcoma community, in which thanks to a collaboration with European opinion leaders and US opinion leaders, and nowadays also with Asian and Australian opinion leaders, they founded the so-called Transatlantic Retroperitoneal Sarcoma Working Group that deals mainly with retroperitoneal or intraperitoneal sarcomas. And this kind of joint venture, which started in 2016, was possible to write down a good number of studies based on a huge number of patients, thanks to which it was possible to write statements, to write guidelines, to demonstrate or to make research about the quality or the appropriativeness of certain treatments. But also for rare cancers needs other kind of tools, the acceptance by the scientific community of alternative methods of research, such as Bayesian models or using surrogate outcomes appropriate tools, things that nowadays for classical research are methods not accepted. But as far as we're dealing with low number of people or low number of patients, we have to modify our research methods. The European Journal of Surgical Oncology, which is the official organ of the European Society of Surgical Oncology, published a monography about rare cancers. The ESO is committed in the task of raising awareness in the importance of the proper rare cancer treatment. This monography has been published in 2019. As you see here, some main aspects of the treatment challenges of different families is considered, but not only this, as you see here, also other aspects, multidisciplinary aspects are stressed, such as epidemiology, such as the second opinion issue, which is very important, such as the problem of networking, the surgical challenge per se, and the methodological approach, as I told before. So we are facing to the end of this webinar with some take-home messages, by which I will try to abridge and to resume some things I've told. The first thing I have to say that one of the great needs in rare cancer is to define high quality centers and a network of care by a process of accreditation. That's very important. That needs a collaborative effort among disease thought leaders, politicians, advocates, and scientific society. We in Europe, we are making a great effort about that, but we still have a lot of work to do. For properly dealing with rare cancer and to in some way obtain better results and to fight inequalities, is needed that networks of rare cancers are established. The networks have the aim to ensure that patients have access to the expertise. And special attention should be shown to the tumor types which are less organized in networks, male genital tumors, rare thorax tumors. And as I told before, to evaluate these networks, it's important to develop a set of standards, taking into account the existing difference between the different countries. As you see, to build up a network is not easy because we had to take in mind 5 issues: management, decision-making, care delivery, research, and education. So it's an important task that can be ignored by rulers, by the European Union, in my case, being European, and so on. In addition to regional access centers, it's very important that local centers, less complex local centers, must be identified in order to be able to deliver less complex care under the advice and guidance of the main centers. So there is the need of organizing a sub-networking or an integrated networks. Integrated networks, as I told before, increase accessibility and minimize the burden of traveling long distances. And that is one of the main issues in concentrating the specialty in several centers. Low access to proper treatments is likely higher in underserved areas. So to build up a network and overcome this kind of problem. Another important issue in rare cancers is to struggle to inequalities by training programs by high quality centers. So the creation of expert centers is in underserved geographic areas, rather to refer all these cases abroad. We are in ESSO, we have developed 2 schools for that. One school that dealing with soft tissue sarcoma, and another school that deals with peritoneal surface malignancies, as a little effort towards this direction. And last but not least, we think that it's very important to involve patient advocacies, because we need that our patients have a good knowledge and ability to take decision, to choose the place in which to be cured, to secure access to innovative or complex treatment, and to support research, because politicians and the source of financing are very sensible to the advice of people. And the importance also is the strong advocacy at the national health policy level. And with this slide, I thank you for your patient listening to me, and that's all. Thank you very much.